back to our show. I'm very excited today. We finally reached with Jivianne Lee for her talk. Unfortunately, previously we had some issues in regards to the presentation, so we tried to solve this. Good morning, Jivianne.
Good morning, Puya. Thank you so much for inviting me again to be part of this landmark virtual session. I really appreciate the opportunity. Hopefully we'll be able to circumvent the technical issues, and I'm really looking forward to giving you this lecture and engaging with your audience.
Great. So Jivianne today, as previously said, she's going to talk about chronic rhinosinusitis. This is one of our most interesting topic, which is currently under review. There are so many debate on surgical procedures, recalcitrant chronic sinusitis. And in fact, tomorrow, Jivianne, she's going to be once again part of our international ground rounds, in part member of the Women in Rhinology, and I'm so excited about this. So let's go back to our to the topic of today. And in regards to the question and answer, please, if anyone is having kind of a questions that is really interested in, please type your questions and we are going to reply on this at the end of the presentation. So let's go back to the presentation from her, and remember that all the questions should be asked now in order to be replied after that.
Today I'll be discussing novel surgical procedures for recalcitrant chronic rhinosinusitis. It's been estimated that over 500,000 individuals in the United States currently suffer from what's termed as refractory or recalcitrant CRS. And this has been defined as CRS that persists or recurs despite appropriate medical therapy and endoscopic sinus surgery. Fortunately, there's been a plethora of novel medical and surgical interventions that have been recently developed to help us with these challenging patients. So starting with the frontal sinus, we have this relatively new outside-in approach to the modified endoscopic Lothrop, as well as expanding indications for the Draf III. With respect to the ethmoid, we have the Reboot procedure. For the Sphenoid, we have the Drillout, also known as the Sphenoid Draf III. In terms of the maxillary, we have the Mega-antrostomy and the Endoscopic Denker's procedure. And we also have various in-office procedures that we can perform to help us with these recalcitrant CRS patients. So starting with the outside-in approach to the modified endoscopic Lothrop, this technique was developed by Richard Harvey a few years ago. It involves removing the mucosa overlying the frontal process, creating a septal window. And then you drill down the remaining upper bony septum in the midline until you reach the nasofrontal beak. You then drill the bone laterally until you reach the nasal skin anteriorly and the lamina posteriorly. And then eventually, as you continue to drill through the midline, you're going to encounter the mucosa of the floor of the frontal sinus. And then you can just enlarge the Draf III cavity just like you would with a traditional endoscopic Lothrop and connect it posteriorly to the frontal recess. So if we were to compare the traditional versus this new outside-in approach, with the classic Draf III, usually we use an angled scope, place a 70-degree diameter inside the frontal sinus, and then drill anteriorly through the nasal frontal beak. So in this situation, we're starting from inside the frontal sinus and drilling in an anterior direction. Now, in contrast, with this new outside-in approach, usually we use a 0-degree scope and a 15-degree burr. In this case, you're just drilling straight up through the nasal frontal beak in the midline until you reach the mucosa of the floor of the frontal sinus. So in this situation, we're starting from outside the frontal sinus and drilling in an inward direction. And that's what gives this method its moniker. So recently, we have had expanding indications for the Draf III. Previously, it was reserved for patients who had failed a Draf 2A or 2B and was actually contraindicated in patients who had a narrow AP diameter or extensive neoosteogenesis, since there just wouldn't be enough space to place the drill inside the frontal ostium itself. But this is actually the ideal candidate for the outside-in approach because, again, with that technique, we're just drilling a straight up through the nasal frontal beak to reach the interior of the frontal sinus itself. Now, recently, the Draf III has also been used for patients with recurrent nasal polyposis. There was a retrospective review that was published by Wormald's group, which looked at 300 nasal polyp patients. And what they found was that the revision rate for a Draf 2A was almost 40% versus only 7% for a Draf III. So their conclusion here was that the Draf III significantly reduced the risk of nasal polyp recurrence in patients with asthma and aspirin sensitivity in particular. So just to give you an idea of how useful this can be, this is a case of a 54-year-old male who had had 8 prior sinus surgeries for nasal polyposis. His past medical history was significant for asthma, but he had no aspirin sensitivity. He presented with purulent rhinorrhea, anosmia, and nasal obstruction that was refractory to steroid irrigations, culture-directed antibiotics, and he was actually self-medicating with prednisone. So here's what his nasal endoscopy looked like. You can see polyps filling the nasal cavity on both sides, from the roof almost all the way down to the floor. And here's what his imaging looked like. You can see that the dependent sinuses actually look pretty clear. Most of the disease is concentrated in the superior ethmoid cavity and the frontal sinuses, which you can imagine is probably because you have adequate penetration and distribution of the topical steroid irrigations in the lower sinuses, but it makes it more challenging to reach some of the superior sinuses, including the frontal recess and the frontal sinus itself. So I ended up taking the patient for revision endoscopic sinus surgery. I started out with a full house vest, removed the polyps in all 8 sinuses, rewidened the ostium. But this time, when I reached the area of the frontal recess, I decided to proceed with the Draf III. And now I find myself doing somewhat of a hybrid of the 2 approaches. If I can, I still prefer to identify the frontal ostium posteriorly within the frontal recess, create my septal window, place my 70-degree diameter inside the frontal ostium, and then drill anteriorly through the nasal frontal beak. Now, with this traditional approach, it is absolutely critical you have an adequate AP diameter so that you completely accommodate the drill without risking injury to the skull base posteriorly. And then you just remove the intervening bridge of bone between the 2 ostia. Now, in contrast with this outside-in approach, usually we use a needle tip bovie, make a mucosal incision along the roof of the nasal cavity and the superior septum and the axilla. You then use your suction freer to elevate the mucosa posteriorly until you reach the first olfactory neuron. Now, alternatively, you can just take a suction bovie and ablate the mucosa, since it's going to be removed through the course of your drill out anyway. You can then use a series of drills to drill all of that thick bone laterally until you reach the nasal skin anteriorly and the lamina posteriorly. You then do the same on the contralateral side. And then once you identify the lateral limits of your Draf III cavity, that's when you can drill straight up through the nasal frontal beak in the midline until you reach the mucosa of the floor of the frontal sinus. But again, if I can, I still prefer to identify the frontal ostium posteriorly within the frontal recess, and then I come back anteriorly and start drilling in an outside inward direction. Because then at least I have some idea of how far I'm going to need to drill. And ever since I started doing this technique, I have found that my Draf III cavities are much larger, both anteroposteriorly and laterally. And I have also noticed that ever since I started doing the Draf III approach for my recurrent nasal polyposis, it does seem to at least retard the nasal polyp recurrence, presumably because of better distribution of the topical steroid therapies. So moving on to the Reboot Approach, this was a procedure that was developed by Klaus Bockert. It's also been recommended for patients with refractory nasal polyposis, particularly those with the type 2 endotype. And it is somewhat of a departure of our traditional mucosal sparing endoscopic sinus surgery in that it involves maximally removing and stripping all of the diseased sinus mucosa. And the rationale behind this is that it can promote healthy re-epithelialization of normal mucosa. So with the complete reboot, this was described by Klaus Bockert in Laryngoscope last year. This procedure involves doing a Draf III and then removing all the diseased mucosa within the frontal, ethmoid, sphenoid, and maxillary sinuses. So everything that you see in here, that's green, and then you preserve all the mucosa that's in red. And then with the partial reboot, this involves a full house ESS and then removing all the diseased ethmoid, sphenoid, and maxillary mucosa. So you don't do the Draf III and you don't touch the mucosa of the frontal sinus. So here's the corresponding endoscopic photos, and these are all courtesy of Klaus Bockert. So this is the partial reboot, where you do the full house ESS, and then the complete reboot, where you do the Draf III and then remove all the diseased frontal, ethmoid, sphenoid, and maxillary sinus mucosa. So Klaus did publish his experience with the reboot procedure in Laryngoscope last year. They looked at 50 type 2 patients with CRS with nasal polyposis. 20 of the patients had a classic mucosal sparing endoscopic sinus surgery, and there was a 45% recurrence in 2 years. 18 patients had a partial reboot with a recurrence rate of 17%. And then 12 patients had the complete reboot with a recurrence rate of only 8%. So their conclusion here was that the reboot procedure significantly reduced the risk of nasal polyp recurrence versus a standard endoscopic sinus surgery. And this was after almost a 3-month. So moving on to the sphenoid, we have this sphenoid Drillout procedure that was developed by Don Leopold, and it's very similar to our endoscopic transsphenoidal approaches to the pituitary in that it involves removal of the bilateral sphenoid base from the planum down to the floor, the inner sinus septum, and the posterior nasal septum to create this common outflow tract. So in his series of 10 patients with recalcitrant chronic sphenoid rhinosinusitis, these patients were successfully managed using this approach. So I found the sphenoid Drillout to be very useful in patients who have had multiple sinus surgeries and neoosteogenesis of the sphenoid or hypoplastic sphenoid sinus. But just to give you an example, this was a case of a 68-year-old woman who had 2 prior sinus surgeries, now with recalcitrant sphenoid CRS. So as you can see, it's very similar to our endoscopic approaches to the pituitary, except in this case, the anterior face of the sphenoid is comprised of this very thick osteatic bone, so you usually have to take a series of drills to burr all of it down so that the bone is thin enough that we can use our standard straight mushroom punch forceps to remove the remainder of the anterior wall of the sphenoid sinus and actually reach the interior and the lumen of the sphenoid itself. And then once we have an adequate opening into the sphenoid on one side, the next step is then to connect it to the contralateral sphenoids. In this case, I just used a ball probe to perforate mucosa on the contralateral side. Then you can use a backbiter and a series of drills to take down the vomer, as well as the keel, similar to what we do for any transsphenoidal approach to the pituitary. Drill down the inner sinus septum. So at the end of the procedure, excuse me, both sphenoid sinuses drain into a common outflow tract. So that's why sometimes the sphenoid Drillout procedure is also known as the sphenoid Draf III. So moving on to the maxillary, we have what's known as the Mega-antrostomy, which is really a modified version of an endoscopic medial maxillectomy. So this technique involves extension of the antrostomy to the posterior wall of the maxillary sinus as well as the floor, with removal of a portion of the inferior turbinate, but the nasolacrimal duct is preserved. And this is very useful for patients with recalcitrant maxillary CRS who have had multiple sinus surgeries. I think the one caveat I would make sure to emphasize is that, especially for those patients who have had a previous Caldwell lung, it's very important to make sure and drill out all of the bony compartments and loculations that may have developed and may be filled with pus. So here is an example of a 58-year-old male who had had multiple sinus surgeries in the past, 2 of which were a Caldwell lung, now with recalcitrant maxillary CRS. And I think what's interesting here is that you can appreciate that there's these multiple bony compartments completely filled with pus from where the previous fragments of the Caldwell lung had collapsed inward. So here's what it looked like intraoperatively. I started off by removing the scar tissue, reopening up the antrostomy and trying to connect it to the natural ostium of the maxillary sinus, debriding all the scar tissue. And initially, it may appear as if you just happen to have a shallow antrostomy. That's the extent of your maxillary sinus, but we know from the scan that there's these multiple bony compartments that we have to open. So here was this second loculation just above the inferior turbinate. And then there's a superior lateral loculation completely filled with pus, where I used a series of frontal sinus instruments and giraffes to remove the bony fragments connected to the natural ostium. Then I proceeded with the Mega-antrostomy, removed a portion of the inferior turbinate, and then used a series of drills to burr down the medial wall of the maxillary sinus from the superior aspect all the way down to the floor. And you can see that as I proceeded inferiorly, I was able to expose additional loculations, also completely filled with pus and sequestered by bone, until I reached this 4th and final loculation along the nasal floor that again was completely filled with pus. So here's what it looked like at the end of the procedure. You can see very nice large Mega-antrostomy where all the compartments are now one common cavity. So there was that lateral compartment that's now connected to the natural ostium, the initial shallow antrostomy, compartment just above the inferior turbinate, and then this 4th and final loculation that we could only access. So with the Mega-antrostomy and removing this medial wall of the maxillary sinus down to the nasal floor. So if we look at the evidence of the use of Mega-antrostomy for recalcitrant maxillary CRS, the largest series came out of the Stanford group, where they looked at 122 patients. They were able to show sustained improvement in their initial cohort of 28 patients after 7 years, and a significant reduction in SNOT-22 lung Kennedy scores after 2 years in the new cohort. There was also a case series out of MUSC, which was able to show no need for revision surgery after almost 3 years with this procedure. And then finally, there was also another study out of the University of Alabama, which showed that it was also very effective for patients with recalcitrant CRS and cystic fibrosis. So moving on to the endoscopic Denker's approach, this is a procedure that was originally described to remove tumors involving the anterior and inferior portion of the maxillary sinus and infratemporal fossa, but recently it has been used for patients with recalcitrant maxillary CRS as well. So this technique involves making an incision along the piriform aperture in the junction of the nasal floor and the lateral nasal wall. We then elevate the soft tissue overlying the anterior wall of the maxillary sinus, taking care to preserve V2. We then use a series of drills and burrs to create a bony window through the anterior wall of the maxillary sinus, connect it to your endoscopic medial maxillectomy, And then this gives you very wide access, not only to the maxillary sinus, but also the pterygopalatine and infratemporal fossas as well, which is why it's used to remove tumors in those areas. Now, recently, there have been some modifications to the endoscopic Denker's procedure. You can do the prelateral approach, which is essentially the same technique, except you don't create a lateral bony window through the anterior wall of the maxillary sinus. You just remove the bone medially around the piriform aperture. And then conversely, we also have what's known as an endoscopic anterior maxillotomy, where you don't touch the bone medially around the piriform aperture. You just create a bony window laterally through the anterior wall of the maxillary sinus below B2 and the anterior superior alveolar nerve in order to reduce the risk of facial numbness and piriform aperture stenosis. So I still actually haven't had to use the endoscopic Denker's procedure for a patient with recalcitrant maxillary CRS, but I thought at least to show you the techniques or familiar with what it involves. So this was a case of a 53-year-old gentleman with recurrent maxillary IP, actually involving the anterior portion of the maxillary sinus. So usually I start off by doing my injections into the anticipated incision sites, and then I take a Bovie to make the incision at the junction of the nasal floor and the lateral nasal wall, an anterior incision at the piriform aperture, and then use a suction freer to elevate the soft tissue and expose the anterior wall of the maxillary sinus, taking care to preserve the tube. And then I use a series of burrs, or you can also use osteotomes to create a bony window through the anterior wall of the maxillary sinus, just like we used to do with the Caldwell-Luck, except this is being done endoscopically. You could then raise the soft tissue overlying the lateral nasal wall, taking care to preserve the nasal lacrimal duct. So at this point, I've done what would have been considered an endoscopic anterior maxillotomy, and that should be sufficient in a majority of cases, especially for recalcitrant maxillary CRS. But if you ever encounter a situation where you may have a very lateral loculation, you just don't have enough access, you can connect it to your endoscopic medial maxillectomy like I did here. And in this case, I did have to deal with the IP removal. But once that's removed, you can really appreciate the type of exposure the endoscopic Denker's procedure gives you. The entire posterior wall, lateral wall, and floor of the maxillary sinus are easily accessible, even with a 0-degree scope, as well as the pterygopalatine and infratemporal fossas. I wanted to switch gears and just briefly review some in-office procedures that could also be used for recalcitrant chronic rhinosinusitis and nasal polyposis. Just to give you a few examples, we do have the in-office steroid-eluting ethmoid implant. This is an 8-pronged implant that releases 1,350 micrograms of imidazole over 90 days, and it's used to treat recurrent nasal polyposis in the ethmoid cavity. So this is what it looks like at day 0 pre-implant. And here's what it looks like immediately post-implant. At day 30, you can see that the polyps have begun to recede in size. And then by day 90, the ethmoid cavity is completely clear, an outcome that was sustained over the course of 6 months. So here's just a video illustrating placement of this implant in the clinic setting with the patient awake. You can see that it does have a rather wide diameter. It does have a stiff composition. So sometimes I do have to inject the septum in the lateral nasal wall just for patient comfort. But once you go more posteriorly, usually these patients have already had sinus surgery. So you can just embed it within the polypoid tissue. And I do think it's important to take the time to position these steroid-eluting implants just right so that you maximize the apposition between the implant and the polypoid tissue that's actually receiving the steroid. So here's what it looks like immediately post-implantation. So there was a multi-center, single-blinded randomized trial which looked at the efficacy of this ethmoid implant. It included 100 nasal polyp patients where the implant was placed on one side and then a sham procedure was done on the other. And they were able to illustrate a significant reduction in polyp grade and ethmoid sinus obstruction in the implant arm versus the control group. also wanted to show you another case again where sometimes recalcitrant CRS can be managed in a minimally invasive approach in an awake patient in the clinic setting. So here was a case of a 68-year-old male who had had 4 prior sinus surgeries for a chronic rhinosinusitis, presented with a 1-year history of left-sided frontal headache that was refractory to medical therapy. And here's what his imaging looked like. You can see that there isn't too much disease. He just has some mucosal thickening of the frontal sinus on the left. Looks like there are some residual fragments obstructing the frontal recess. So the patient actually declined to have any additional surgery in the OR. So I decided to try and open up this frontal sinus in the clinic setting instead. So here's what it looked like. Endoscopically, you can see that there are some residual fragments in the frontal recess as anticipated based on the scan. So I started off by doing my injections into the axilla and the middle turbinate, just like we typically do in the OR, then used cobras and various frontal sinus instruments to resect those residual fragments that were obstructing the frontal recess. And then I could begin to appreciate what looked like the natural ostium of the frontal sinus, just posterior to this residual cap of the auger. So I did place a balloon device with the seeker into where I anticipated the frontal ostium would be. Went ahead and dilated it to 12 atmospheres, and then deflated it and then removed the device. So at this point, I didn't have any in-office navigation. So I did use trans-elimination, and fortunately, it did pass relatively easily. And you can see that there was a lot more polypoid inflammation than I would have expected based on the imaging. So I did go ahead and decide to proceed with the Draf II in the office, used cobras again to remove the cap of the auger, used the light seeker to confirm my position with trans-illumination since I didn't have any navigation in the office setting, tried to take out some of the nasofrontal beak, then used giraffes to remove some of the polyps within the frontal sinus proper. And this was about as good as I could get it in the office setting. Here I used some Hosman forceps again to try to resect some of the beak. You can see there's still some polypoid tissue up in the superior aspect of the frontal sinus, so I decided to place a steroid-eluting implant up into the frontal sinus proper in the hopes that the combined stenting function and steroilution would help to treat some of the polypoid tissue that I had left behind. And as I mentioned earlier with the in-office steroid-eluting ethmoid implant, I do think it's important to take the time to position these implants just right, so then you can maximize the interface between the implant and the polypoid tissue that's actually receiving the steroid. So in this case, since I'm trying to treat the polypoid tissue within the frontal sinus proper itself, try to push up the implant so that its inferior aspect abutted the natural ostium of the frontal sinus. So here's what it looked like 3 weeks and then 6 weeks later. And you can see that the frontal sinus is nicely patent. That outcome was sustained over the course of 6 months. So hopefully, this lecture kind of showed you sort of the wide spectrum of surgical innovations that we have in our treatment armamentarium for recalcitrant CRS, from the more aggressive approaches like the outside-in Draf IIIs, the Sphenoid Drillouts and the Reboot procedures, the Mega-antrostomy, the Endoscopic Denkers, to less invasive approaches like the steroid-eluting implants or in-office Draf IIAs that we can do in the clinic setting. Right, so thank you very much, and I just wanted to make sure to invite you all to our American Urologic Society 9th Annual Summer Sinus Symposium, which will now be virtual, and it'll be held on November 14th through the 15th of this year. All right, thank you very much.
So thank you, Jivianne, for the presentation. I really like the whole new techniques, and I really love the stent for the frontal sinus, which is currently not so easy to have in Italy. I don't know the situation in the US. So we will go through this because we have plenty of questions around the world. So let's go straight. Let's go straight to the question, if you don't mind. So great presentation as usual.
Thank you very much.
Sending cheers from Ecuador, from the US, from India, and whatsoever around the world really enjoyed it. Hungary, Sweden, and others. So the first
That's
question
great.
is, does the steroid-eluting ethmoid implants really work? How long will it last?
So the in-office steroid-eluting ethmoid implant typically lasts about 90 days, but most of the steroid elution probably happens within the first 2 months. I was part of the initial like multi-center clinical trial. And what I would say is, obviously the case I showed you worked out really well. You saw that there were no recurrence of the polyps, but it's not like that in every patient. Just like, with all our different therapeutic options, I think it can be highly variable and patient dependent, but I do think it's nice to just have another option for these patients, that's minimally invasive. There's a lot of patients that may not necessarily want a biologic and to get, shots, every 2 weeks or once a month. And then there's other patients who may not want to have a Draf III. So I think it's just nice, to have another option that you can do in a patient just under local anesthesia. And you saw it's pretty easy to place. You can, you just maybe do some injections in the septum and the lateral nasal wall. And then these are patients, though, that all have had previous sinus surgery. So they have to have had an ethmoidectomy. Otherwise, there's just not enough space to put the implant at all. But I think it works pretty well. Like I said, you can swap it out, every 3 months. It's not perfect. Sometimes, it can get infected. I've seen that since it's still a foreign body, and I've had to give antibiotics. But for the most part, those patients that like it and ascribe to it, they definitely prefer that over maybe getting another course of prednisone, for example.
Yeah.
But it is available for us now. It's not as challenging to get as it was when it first came out.
It is actually so many people are interested in those implants because there's plenty of questions after you just posted this. One of those questions are, um, does the implant cause any foreign body reaction?
Yeah, it's not perfect, like I said. So in some patients, it works amazing. So I showed you two different kinds. Like one was the in-office ethmoid implant, which is for recurrent polyps, right? But there's also the one that I use pretty routinely at the end of surgery to try to keep the frontal ostium open. And in those situations, sometimes you can get, a bit of a foreign body reaction, even though the initial histological studies seem to indicate otherwise. I have seen that in some patients. They can get like a Pseudomonas infection. So I have given some fluoroquinolone antibiotics, even prophylactically, at least for the first couple of weeks. So the ethmoid implant that I talked to you about for the polyps lasts 90 days, but the other one is different. The one that goes into the frontal sinus, which is a little smaller version and a little more elastic, that one dissolves over the course of about 6 weeks, 4 to 6 weeks, and you can actually take that out ahead of time. So what I've been doing is I actually remove it around 2 weeks because it starts to break up and dissolve, and that way it's not in there necessarily long term. It just helps in the initial postoperative healing, so it can treat some polypoid inflammation and prevent scarring at the same time.
Good. Another question is from our friend Ashwin. It said, convincing patient for revision surgery itself is a difficult job. Isn't sphenoid drill out a bit overkill for recalcitrant sinusitis?
It's interesting. I have found myself, using it more and more. And I think, when I showed you some of these different procedures, I mean, there's no question that it was the whole spectrum. All right. So you have, the really more aggressive procedures, like considering like a Denker's or Mega-antrostomy and the Sphenoid Drillout, and then the more minimally invasive things that we could potentially do in the office setting. And I think, it comes down to that whole idea of individualized medicine or personalized medicine, where we really have to take each patient on a case by case basis. But like in that patient that I showed you there, I mean, she had already failed multiple surgeries. And if you just open the sphenoid, on one side, you can get neoosteogenesis again. It can just close up. So I have found myself using it more and more, surprisingly. And, we already do transfodal approaches to the pituitary anyway. So from a technical perspective, it's really not much different. We already have the skill set to do that. And it's actually much lower risk, I think, than especially like a Draf III, which is a little bit more morbidity. I think the only difference here for the patient is that they have a lot more crusting during that first 3 to 4 weeks post-op, where you have to debride out that posterior septal window. But I have actually done it more and more than I would have expected, again, for these patients with a lot of neoosteogenesis or a hypoplastic sphenoid, sometimes even for fungal sphenoid sinusitis or mucocele, where, I want to try to make sure it stays open. So I actually think it's much easier to do and less invasive than, for example, like a frontal sinus Draf III and less risky. That's just my personal opinion, but I found it works really well.
There's a question. It's fascinating, but I would love to change a little bit this question and take it to up to date. This colleague is asking, with a lot of nail osteogenesis and fibrotic mucosa in the maxillary sinus, how do you manage to clear this salt of mucosa? And here's my edits in this. Would
Mm-hmm.
you recommend now in this COVID-19 situation to schedule a patient for such cases?
I'm sorry. Could you repeat the question, Puya? I think the audio kind of
Absolutely.
came out for a sec.
So the question is, with a lot of nail osteogenesis and fibrotic mucosa in the
Mm-hmm.
maxillary sinus, how do
Yes.
you manage to clear that salt of mucosa? And my question is, not only this, but it's this related in this COVID-19 situation, which is actually going on. And that's why we, as you said, we have to tailor every procedure to the patient. So in this case, would you recommend, and what do you recommend in such cases?
So you mean for a patient who has neosteogenesis of the maxillary sinus, where they still keep getting chronic infections? Yeah, I mean, I think it's a challenging case, with or without COVID. Um, I think you don't really have a choice. Like if there's bony loculations, like what you saw in that case that I presented, I mean, he had multiple surgeries already, the Caldwell Lux, and I think the Caldwell Luck almost is one of the harder patients to deal with, mainly because, like I said, if they've had that previous Caldwell Luck, it tends to cause the maxillary sinus almost to shrink inwardly. And so then you get all these bony fragments that kind of collapse inward. And then you get these loculations that are completely encased in bone and filled with pus. So, I think in that situation, if they aren't responding, to antibiotics, and you've tried giving culture-directed, medical therapy over and over again, then I think you have to just go ahead and do the Mega-antrostomy. It's also known as, the modified endoscopic myomaxillectomy. And you can't just open the antrostomy, but you have to take the time and drill out each one of those, bony compartments and make sure you drain all of the pus. There's really, I can't think of really any other option except to just drain the infection. And ever since I did that, he's been doing so well. So sometimes, there's just no substitute to just physically going in and surgically draining each of these pus pockets, even if there's a lot of neoosteogenesis.
There's a question from YouTube, and this colleague is a resident, and say, what are your landmarks for revision surgery for the frontal sinus?
So, I think it kind of depends on what was done previously and what was removed. Obviously, if the middle turbinate is still there and the attachment, I think that's really helpful. You can identify the axilla, which is really useful. And if the cap of the auger is still there, I think that's also obviously a great landmark, and then your skull base. But I think otherwise, you just have to sort of, recognize what landmarks were distorted, what's been kept, and usually what's still there uniformly, obviously, is the lamina. So that can be a great landmark for your frontal recess dissection laterally. Then medially, obviously you would look at whatever remnant of the middle turbinate there is. So that would be sort of the medial and lateral limit. Posteriorly, you still need to clear out your skull base, just like you would in any traditional endoscopic sinus surgery. So I usually try to go from posterior to anterior when I'm doing the skull base dissection. And that way you at least clear all the partitions from the planum all the way to the ethmoid roof. And then once you identify then that natural ostium of the frontal sinus, then you can just enlarge it just like we would with any primary sinus surgery. I think the challenge is when you can't find the frontal ostium for whatever reason. And that's when I think, the outside-in approach to the Draf III that Richard Harvey had talked about can be very useful. It always makes me a little bit nervous because you're still going blind. You're actually relying a little bit on the navigation for that approach, where you identify the nasofrontal beak using the surgical navigation. And then same thing, then you identify, the lateral nasal wall, but then you're really just drilling straight up in the midline through the nasofrontal beak to get to the mucosa of the floor of the frontal sinus. So there's no question that, as you're drilling and if you don't have that frontal ostium already open in the frontal recess, I do find myself wondering, like, gosh, when am I ever going to get to the frontal sinus? But that's when I think the navigation is absolutely critical. And it's not ideal to rely on that. Like, this is if you don't have any landmarks at all, but I think it's certainly helpful. But like, if you can, I think you should still try to find your frontal ostium, even if the middle turbinate's gone, the lamina's gone. You should still be able to get into the ostium in the frontal recess posteriorly, and then you can go ahead and proceed with your Draf III approach.
There's a question from LinkedIn, and it's quite interesting. This colleague is asking, if you have a septal perforation and the patients present with the recalcitrant sinusitis, would you schedule these patients for a revision surgery, or would you address medical therapy?
I think it depends, on where the sinusitis is and what the anatomy is. So, if the sinuses, if there's a septal window already, and the sinus is already open, like, let's say, like, all the osteotomies are really widely patent, from a traditional, like, full house ESS, I think it's worthwhile to try medical therapy. First oral, obviously, culture directed antibiotics. I know there isn't a lot of level 1 evidence for topical antibiotic therapies, but I have had some moderate success with that. If the patient's on, 30 days of whether it's mupirocin rinses or ceftazidime rinses, depending on what bacteria grows out of the culture. And as long as there's wide enough openings, I have found some success with that. So I think it's always worthwhile to try medical therapy before you jump to surgery. Now, obviously, if the patient fails that over and over again, then there's really no other option but to try to expand whatever opening is pre-existing. And so a lot of the procedures I showed you is assuming that the patient's already had some kind of full house, ESS, where your traditional endoscopic sinus surgery has already been done, all the sinusotomies are already open, and they're still failing medical therapy. Then I think you have no choice. If it's the frontal, I would go ahead and do the Draf III. If it's the sphenoid, I would do the Drillout, and then if it's the maxillary, I would do the Mega-antrostomy. Or if they don't want more aggressive surgery and it's amenable, then I would try doing a balloon dilation and trying to treat it that way. But I think it really depends on the patient. But I think medical therapy would always be first. The one thing I've had absolutely no success with is IV antibiotics, and I think a lot of the consensus statements, both out of Europe and the US, have pretty much agreed that there's just no evidence to support the use of IV antibiotics in these recalcitrant CRS patients. I pretty much had no success with that.
Exactly. So I think that we on time. I would suggest to all the attendees, if you have any questions, please. If there's a possibility, Jivianne, if I can address them, if you have any kind of email, if they Absolutely. Can, if they want to send you any questions, because that's the way we love to have support from our faculty member to our guests, so they can interact each other. We have so many questions from the residents, so I think that so many will join you for questions. So for anyone interested, this is going to be recorded and available on our social media channel. And in case you're interested, tomorrow we are going to have a woman in rhinology panel on fungal rhinosinusitis. It's going to be a huge one. I'm very excited about this. But if you have questions for Jivianne, she's very kind, and I think that she will probably reply as soon as she can, because situation nowadays is not so easy to manage, and we have to find a way. I'm really glad that for your participation is very early in the US. So thank you for joining, for the opportunity to having you here. And I see you tomorrow. And for the others, tune in tomorrow afternoon Italian time and early in the morning for the US. Thank you, Jivianne, for being with us.
Thank you so much, Puya. It was an honor to be here. And thanks to all of the attendees for taking the time to still engage with us and attend these virtual sessions. Hopefully I can go back to Italy in person in the future at some point.
Ciao, ciao.
Thank you.